Hello everyone, welcome back to our channel. I'm Dr. Ashmita. Today I want to discuss about a clinical scenario which is presented as an OSCE chart during the practical exams for the second year MBBS students, also helpful for the postgraduates. So let's begin by reading out this question. A 6-year-old child presents with malaise for 3 weeks, oliguria, urine output less than 500 ml per day for 4 days, and smoky urine. On examination, child was hypertensive, that is 170 by 112 mm Hg and had peripheral edema. Investigations show blood urea 39 mg per deciliter. The normal urea range in this age group, in the pediatric age group under 17 years, is 5 to 18, and creatinine 4.3 mg per deciliter, the normal value ranging from 0.3 to 0.7. The complements like C1q, C3, C4, they are decreased. Urine proteins 1 plus, blood 3 plus, glucose nil and ketones. These are present in urine. And urine microscopic pictures given below. So from this question, what are the clues that we can get? So given it is a 6-year-old child, it is a pediatric age group, symptoms for 3 weeks. So 3 weeks history. It indicates a latent period. It's a latent period of infection. So after primary exposure to an infection, the symptoms are persisting for 3 weeks. It indicates latent period. And there is oliguria, less than 500 ml per day output. And this is smoky urine. Smoky urine is nothing but a cola colored urine. It is a cola colored urine. This is a cola colored urine. This is a cola colored urine. It is similar to the Coca-Cola drink. So this is cola colored urine is present, and this child is hypertensive. Given the BP 170 over 112, so hypertension is present, and he had peripheral edema. Peripheral edema means that is limited to the extremities. They are not generalized edema, only limited to the extremities. Therefore, it is a mild edema. A mild edema, unlike anasarca, that is generalized edema, which is a severe kind of edema. Here, this edema limited only to the extremities, also called the peripheral edema, is regarded as the mild edema. And the investigations, blood investigation showing raised blood urea and creatinine. It indicates azotemia due to decrease in renal function. And there are low complements. So C1q, C3, C4 all are decreased. So low complements in the blood, that is called hypo means less, hypocomplementemia. Complements are low in the blood. Emia means blood. And coming to the urine examination, proteins are present. 1 plus means mild proteinuria is there. Mild proteinuria and blood 3 plus. So there is hematuria. Good enough hematuria is present. Glucose nil and ketones nil, they will rule out. It rules out diabetes mellitus. And a microscopic picture of urine examination shows you certain cylindrical structures. These are the cylinders. And the cylinders, they have certain base, that is the embedding tissues, embedding surface is there, over which there are certain cells are seen. These cells with a clear cell outline. So clear cell outline, and there is like no nucleus or granules inside these cells. These are like plain. These are plain cells only with a cell outline, regular cell outline. These are nothing but RBC. So here the cast, these cylindrical structures are called cast, and since they contain RBCs, they are called RBC cast. So presence of RBC cast is present. From these clues given in the question, what can we infer? So, a 6-year-old child, 3 weeks history. Main importantly, there is oliguria. Cola colored urine means it indicates, that is cola colored urine, it indicates hemolysis. So, hematuria. RBCs are lysed and the free hemoglobin passes out in the urine. That gives a cola colored urine. So, there is hematuria. Hematuria is present, hypertension is present, edema present, azotemia is present, declining renal function, hypocomplementemia, mild proteinuria, hematuria. Okay, as we said, hematuria is because it is, this RBC lysis and it comes out as cola colored urine and this RBC cast passage. All these features, they are the hallmark features of Nephritic syndrome. Nephritic, nephritic syndrome. These are the hallmark features. Presence of hypertension, hematuria, azotemia, oliguria. All these are like the hallmark mild proteinuria and mild edema. These are the hallmark features of nephritic syndrome. And specifically in this given question, since it is a pediatric age group 6 year with a 3 weeks latent period history, it points more commonly to post-streptococcal glomerulonephritis, that is, after a streptococcal sore throat or sore throat, like pharyngitis or the skin infection. These renal manifestations begin after 1 to 3 weeks post-infection. Hence the name post-streptococcal glomerulonephritis, which is common in the pediatric age group, as in this case 6-year-old child. So let us solve the question. We begin with the second question. What is the most probable diagnosis? Post-streptococcal glomerulonephritis, which is a part of nephritic syndrome. Nephritic syndrome. Here it is post-streptococcal glomerulonephritis. So let us discuss in detail about the post-streptococcal glomerulonephritis, which is caused by group A beta hemolytic streptococci. Beta hemolytic streptococci. So it is also called GAPS. So the specific strains of beta hemolytic streptococci that are responsible for the nephritic syndrome are nephritogenic strains. What are the nephritogenic strains? Are 1, 2, 4, 12, and 18. If you can remember 1 to 4, we can remember. And the incubation period for this is approximately 1 to 4 weeks is the incubation period for this organism. And the mechanism here is whenever there is an infection with this group A beta hemolytic streptococci, such as streptococcal pharyngitis, or streptococcal skin eczema, so skin infection. So there is the patient is exposed to this antigen, streptococcal antigen exposure occurs. So automatically antibodies are formed against it. They both combine and form an immune complex. These are called immune complex, which get deposited in the glomeruli. The glomeruli during this latent period they get deposited in the glomeruli. Whenever there is immune complex deposition, there is activation of complement pathways. Complement pathways, both classical and alternate. Therefore, whenever the complement pathways are activated, they consume all the complements in the blood are consumed. Therefore, it will result in the low levels of complements like C1q, C3 in the blood. These are the most common complements going to go down in the blood. C4 is more usually it is normal in very rarely or few cases, they can be decreased also, but usually it is normal. So C1q, C3 are the affected complements. They are always no, lower on a lower side, or they go down in this post-streptococcal glomerulonephritis. And this complement pathway is activated, therefore it leads to formation of membrane attack complex, that is C5b to C9, which are called membrane attack complex. Membrane attack complex. What do they attack? They attack the RBC membrane. They attack the RBC membrane, forms pores in the RBC, cause hemolysis, and the free hemoglobin is released. Therefore, it causes this is indicative of intravascular hemolysis. Also, the C3b is also formed, it is also activated, which coat the RBCs. That is called opsonization. This will coat the RBCs. This is called opsonization. Hence, it is opsonin. C3b is an opsonin. So, it makes it easy for phagocytosis. Phagocytosis by the macrophages present in liver spleen. So this will cause extravascular hemolysis. So this complement activation will lead to formation of both intravascular and extravascular hemolysis. That is the reason why the RBCs are lysed and free hemoglobin pass out in urine, giving a cola color or the smoky urine. This is the pathogenesis behind this post-streptococcal glomerulonephritis. This is the cola-colored urine. This is the cola. Final output is the cola-colored urine. Like a Coca-Cola drink, the color urine color is similar to a Coca-Cola. Hence the name smoky urine, smoky or the cola-colored urine. And certain blood tests which are specific for this post-streptococcal glomerulonephritis are, since it is a streptococcal infection, anti-streptolysin O (ASO) levels are high, and also anti-DNase DNSB levels are high in this post-streptococcal glomerulonephritis. Also, the gross image of a kidney in Psgn, they show certain, like on the outer surface you find this pinpoint hemorrhages, like small focus, small dots, pinpoint. You can just pinpoint them. So pinpoint hemorrhages. These are called the pinpoint hemorrhages. Also called, this gives the kidney a flea-bitten appearance. Hence the name flea-bitten kidney, which is characteristic of post-streptococcal glomerulonephritis. And coming to the light microscopy, on light microscopy, since we have discussed there is immune complex deposition, so this is a glomerular, let us draw a filtration barrier. This is a glomerular basement membrane, GBM. Here are the endothelial capillary cells. These are the endothelial cells that indicates capillaries. Also, here there are podocytes present, podocytes or the visceral epithelial cells. These are the podocytes. So, whenever there's immune complex deposition, first they get deposited in subendothelially. Subendothelial deposition starts first. So, underneath this endothelial cell, there's immune complex deposition. So, the immune response get activated, and then from this blood vessel, neutrophils or the macrophages, they come and infiltrate. So the policeman, and the macrophages of the kidney called mesangial cells. Mesangial cells are the macrophages of the kidney. They come and infiltrate here under the subendothelium. Hence there is mesangial proliferation. Hypercellularity. It appears glomeruli appear hypercellular. And as the disease progresses, this subendothelial deposits also move subepithelially under the podocytes. Under each podocyte, the subepithelial deposits form. As the disease progresses, these are called subepithelial deposits. And if the deposits accumulate in such a way that the podocytes become huge, they become very huge, they accumulate, they become very huge. Hence, these are called subepithelial hump. These are called subepithelial humps that we see in this electron microscope. In the electron microscope, let us identify the podocytes. These are the podocytes. First, we'll identify these are the podocytes. These are also podocytes, but they are different from the normal ones, adjacent ones, because of certain subepithelial deposition, subepithelial immune complex deposition. They form huge humps which are similar to a cattle hump, representing a cattle hump. Please do not use this cattle hump as an example while writing exams or during your viva questions. Just for your remembrance, I'm telling. But you can say it as a subepithelial hump. These are called subepithelial hump. So this is the electron microscopic picture of Psgn. And coming to the immunofluorescence picture, this is the immunofluorescence picture, always appearance like green and black. The green is fluorescent green because it is immunofluorescence. It gives a shiny green color. So shiny green color indicates there is presence of immune complexes. There is presence of immune complexes. Wherever the darker areas are there, there's no immune complexes, lack of immune complexes. So it appears like a starry sky. The sky, the dark sky, is the lack of complements. Here the shining stars here, these are the immune complexes. These are the immune complexes. Hence the name starry sky. Stars represent the complement deposition, and the sky, dark sky, is nothing but lack of complement deposition. This is about the immunofluorescence of Psgn. And let us solve the other questions. So we have completed the probable diagnosis and in depth about Psgn. Coming to the other question, identify urine microscopic picture. In this given question, it is RBC cast. I'll explain why. First of all, let's begin by looking at all other casts as well. This is the first image is of a hyaline cast. Hyaline casts these are also cylindrical structures. These are cylindrical structures. They are almost transparent, hard to notice on a routine examination. Only when you zoom in under high magnification, you can point it out. This is a normal finding because these are secreted by the renal tubular epithelial cells lining the loop of Henle. For example, this is a glomeruli. This is the loop of Henle. And the collecting ducts. This loop of Henle, the cells lining the loop of Henle secrete this hyaline cast, secrete certain proteins which aggregate and form an hyaline cast here. Hence, they take the shape of the cylinder, this loop, which is cylindrical, and hence it appears cylindrical. It appears cylindrical. So hyaline cast, passing of this hyaline cast is normal finding up to 2, 3, 4, 5 is normal. But if it is in excess, like in a slide more than 20, 20, 15 to 20, these are high and it indicates like undergoing fever. Fever can be there, dehydration, stress, or post workout, post exercise, you can say. Under these conditions, this hyaline cast can be excreted in urine in excess quantities. So this protein that is this forming, the renal tubular epithelial cells secreting this protein is called TAM horsefall, TAM horsefall protein. It is an important protein to be remembered, TAM horsefall protein. And coming to this cast, it is again the same cylindrical cast made up of the stem horsefall protein only, but upon it there are certain embedded cells. There are clear cells, like only the cell outlines are clear. Thus only the cell outlines are clear. Like the cell outline is clear without any nucleus, without any granularity. These are the RBCs. So hence it is an RBC cast. RBC, passing of RBCs in urine indicates hematuria. So more commonly it is seen in glomerular injury, glomerular pathology like glomerulonephritis. Glomerulonephritis. It is seen in glomerulonephritis. Coming to this cast, again the same cylindrical structure formed by Tom Horsfall protein, but here the cells are little different than the RBC cast we have seen previously. Here the cell outlines are clear, but inside the cell the cytoplasm is not clear. There are certain like dust-like materials or certain granules are present. This granular appearance of individual cells it indicates WBCs. These are also called pus cells. Pus cells. WBCs in the urine are called pus cells or the WBCs. They have a granular appearance because of this nuclei. It can be either neutrophil or the neutrophilic granules. So because of that nuclear and the granularity, the cell appears highly granular. So this is an WBC cast. This is a WBC cast. Seen in conditions like WBCs are more common in infections like pyelonephritis, pyelonephritis, interstitial nephritis. So all the infections associated with WBC cast passing in the urine. Again, here other cast cylindrical structure. Here certain like droplets are seen, variable size droplets. They appear like oil bubbles. They are appearing like an oil bubble. So these are nothing but the lipid droplets. These are the lipid droplets, variable sized bubbles, or it appear like a shining oil bubble. So passing of this, these are called the fatty cast. Because it contains lipid droplets, it is called fatty cast. Presence of fatty cast indicates this lipiduria. Lipiduria. Lipiduria we have seen in nephrotic syndrome that I have discussed in my previous chart 2 video also. Please look back to it. Lipiduria seen in nephrotic syndrome. So coming to this cast, this is also a cylindrical structure with only dots on it. There is no like clear cell outline. There are no clear cells, only presence of dots like a dust particles spread on it. So this is called a granular cast. This is called a granular cast. It is composed of degenerated degenerated cells. Degenerated cells do not have a proper set line. They do not have proper cell outline. Only the nucleus remains. Whatever nucleus is there, the nucleus remains like a cell dead debris. So it indicates degenerated cells, which can be renal tubular epithelial cells or RBCs or WBCs, whatever it could be. So we cannot come to a conclusion what kind of cast this is, like what kind of cells are passing out, and hence we order for a fresh urine sample because this indicates degenerated cells. This indicate why does degenerated cells stay? Whenever this cast is staying for a long time, it has been staying for a long time in the renal tubules. It cells undergo degeneration and stay stuck there. So we cannot come to a conclusion of which kind of cells are being passed out. So we order for a fresh urine sample. This cast is like a transparent broad ribbon. So this is a called broad waxy cast. So it is like ends are sharp. Here the ends are sharp and it has sharp outlines. It is broad like a ribbon, or else it can have certain convolutions on the surface, like the inner mitochondrial membrane. It can be convoluted like an inner mitochondrial membrane. These broad structures, broad ribbons, these are called broad waxy cast. They are indicative of, they are suggestive of chronic kidney disease. Chronic kidney disease. Here again, this is also transparent material, same like the waxy cast or the hyaline cast as well. But the difference is it is a slightly thinner and wavy, like a thread. It is thread-like. It is thread-like, wavy. This is a mucus cast. Mucus secreted by the tubular epithelial cells under certain inflammatory and infectious conditions. Inflammatory and infectious conditions lead to formation of mucus. For example, inflammatory conditions like cystitis, infections, urine tract infections. In these conditions, mucus cast can be seen. These are the mucus cast. Coming to this variety, this is a crystalline cast. This is a crystalline cast, or simply you can say crystal cast. Here the certain tubular structures are present, but on the tubular structures, certain like cell, it like gives like appearance of some stuck on cells or stuck on crystals present on it. The exact round is present. You can also say why not this is an RBC cast. When we see the RBC cast here, the cells they are one they are one touching one another like a sheet. It gives an appearance of a sheet, epithelial sheet, like how the epithelial sheets are spread. It gives cell is like lying one after the other. Whereas here, it like gives you an appearance of a grape, a cluster of grapes, one above the other, one overlapping of the other, overlapping appearance. You have this one stalk over which the grapes are present. When you look from the top, they have this overlapping kind of appearance. So this gives an overlapping appearance. It is similar to a mulberry. See, when you look at this mulberry, there is a strand, central strand, over which these grape-like clusters are formed. Clusters. They like give an overlapping appearance, overlapping bubble appearance. Very similar to a mulberry appearance, this crystals. Here, the crystal is like round, only the round scar. crystal is present. This is a calcium carbonate crystal. In my first video of this practical chart number 1, I have discussed in detail about the crystals, their morphology. I have discussed car. So the car wheel appearance. Car wheel is a round car wheel with certain spikes on it. So it is calcium carbonate. Here it is calcium carbonate crystalline cast because it is arranged in a cylinder embedded on a cylindrical structure. For other kind of cars, to know the morphology of other kind of cars, please go back to that first part 1 video of the charts. Coming to solve the third question, what are the constellation features of nephritic syndrome? So, nephritic syndrome constellation features are mainly hematuria is present, which appears as a cola colored urine, oliguria, the renal function goes down, so oliguria and azotemia, that is raised blood urea nitrogen and raised creatinine. Again, hypertension, mild peripheral edema is present, and mild proteinuria. These are the constellation features of nephritic syndrome. These five make up the classical pentad of nephritic syndrome. Yes. So let us understand the differences between the nephrotic and nephritic syndrome now. In nephrotic syndrome, there is proteinuria is present, yes, definitely, and it is massive, like more than 3.5 grams per day. Whereas in nephritic, there is mild proteinuria. Mild means less than 1 gram per day, as in this case, in this given question, it is less than 1 gram per day, mild proteinuria. And mostly nephritic syndrome is characterized by mild proteinuria, like less than 1 gram per day. Also, it can be moderate, ranging from 1 to 3.5 grams per day, which is moderate. And in nephrotic, there is lipiduria. So there is lipiduria, proteinuria and lipiduria, like passing of so many proteins and lipid, like fat droplets in the urine. It gives the urine a frothy nature, a frothy, like presence of air bubbles on the top surface. Frothiness is present on the urine surface. Whenever you void urine into a commode, on the upper surface you find this froth, the bubbles. So presence of this huge quantities of froth is called frothy urine, characteristic of nephrotic syndrome. Whereas in nephritic syndrome, there is hematuria giving rise to smoky or cola colored urine because of lysis of RBCs. And there is in nephrotic because of proteinuria in the blood, the protein levels go down, mainly albumin. There is hypoalbuminemia. Also, there is because of hypoalbuminemia, there is edema because of intravascular fluid shift, and there is thrombosis because all the proteins are lost. What all proteins can also be lost, like antithrombin 3, which is a natural anticoagulant, protein C, protein S, they are also lost in urine and they cannot be compensated by the liver. Loss of this natural anticoagulants will lead to prothrombotic state, hence there is a thrombus formation. So thrombosis. In nephritic syndrome, there is, along with this mild proteinuria, hematuria, there is oliguria, there is hypertension, there is azotemia. So all these are the constellation features of nephritic syndrome. So proteinuria, hematuria, oliguria, hypertension, azotemia. Yes, these are the main differences between nephrotic and nephritic syndrome, more commonly asked for viva in the practicals. Coming to the last question, different lesions causing this syndrome, different lesions. So this syndrome is nephritic syndrome. Under nephritic syndrome, many other diseases are present, like firstly post-streptococcal glomerulonephritis, IgA nephropathy, lupus nephritis, which is the renal manifestation of systemic lupus erythematosus, fourth membranoproliferative glomerulonephritis, fifth rapidly progressive glomerulonephritis. Let us see one by one. First, post-streptococcal glomerulonephritis we have discussed in detail More common age group is the pediatric age group. Children are more prone to it. History of latent period of 1 to 3 weeks after throat or skin infection by the streptococcus group A beta hemolytic streptococci is the given history. And in urine, you find this is smoky or cola colored urine. In post streptococcal, cola colored urine is the characteristic finding. Coming to the complement levels, as in the given question, the complements go down. Mainly the C3, C1Q, C3 mainly go down. C4 is usually, in most of the cases, C4 is normal, but in few other cases, it can also go down. And other features are, like other blood tests show, anti-streptolysin O, like presence of antibodies like anti-streptolysin O, anti-DNase B. These are positive. These are positive. And it is a self-limiting disease. The Psgn is a self-limiting. It will resolve by 6 to 8 weeks. It will resolve by 6 to 8 weeks. Coming to the IgA nephropathy, it is common in adults. History of synpharyngitic, like immediately after streptococcal throat or the skin infection, within 1 to 2 days, the symptoms, renal manifestations of hematuria occur. So it is going hand in hand with pharyngitis, hence the name synpharyngitic. Synpharyngitic after the upper respiratory tract infections more commonly. And in urine, you find hematuria, only hematuria is present. Complements, they are normal, they are unaffected. C3, C4 are unaffected in this. Coming to the others, course of illness, because of recurrent hematuria, there can be CKD. Because of recurrent hematuria, there can be CKD. And coming to the lupus nephritis, which is the renal manifestation of systemic lupus erythematosus, which is more common in adults, especially women. Women are more prone because all the autoimmune conditions they are more common in women. Lupus nephritis is more common in the women, adult women. And the history is because it is a systemic disease, history of rash or arthritis and oral ulcers are seen, are common. In urine, there can be hematuria and proteinuria can be seen or cannot be seen. So it is hematuria, proteinuria can be or cannot be present. And coming to the complement levels, both C3, C4 they go down. All the complements go down in lupus nephritis. And coming to the other blood tests like antibodies, anti-neutrophil antibody ANA, anti-dsDNA antibodies are positive. And course it has a progressive kind of nature. If untreated, if left untreated, it will progress. So coming to the membranoproliferative glomerulonephritis, more common age group is adult. History being it has like both nephrotic and nephritic kind of symptoms. Both symptoms are mixed in it. So the urine shows hematuria and proteinuria. Hematuria is of nephritic, whereas massive proteinuria is a nephrotic picture. Since we said they have both, it's a mixed kind of feature, mixed history. The urine also shows hematuria, massive proteinuria. And coming to the complements, here in MPGN there's persistently low C3, but the C4 remain normal or near normal. And others are nil. The course is progressive, membranoproliferative, as the name it is proliferating, and it has a progressive course. Coming to the rapidly progressive glomerulonephritis, it is more common, like it does not have any age specifications, it can occur in any age, and the history is rapid. It has a rapid course, rapid renal failure, and it has a systemic vasculitis. And coming to the urine findings, we find only RBC cast. Rapidly progressive has RBC cast. And complements, coming to the complements, they are variable. Like it can be normal or increased or decreased. Any kind of picture can be seen with regards to complements. And coming to the antibody testing, anti-GBM antibody, that is anti-glomerular basement antibody and anti-neutrophilic cytoplasmic antibodies are positive in this rapidly progressive disease. And coming to the treatment course, it has a severe like worse prognosis, it has a severe course of illness and the light microscopy shows crescents. That is because of extensive mesangial proliferation, it can form crescents like this in the glomeruli. So let us, after completing this table, let us see how to let us once again revise this table. So as we have discussed in this question, particular question of this chart, PSGN, the more common age group is child. For others, mostly it is adults. Lupus nephritis because autoimmune is more common women, adult women you can remember. RPGN has any no age specification, any age it can occur. So PSGN is the only age group for pediatrics, for peds PSGN, peds PSGN. History like PSGN we have studied latent period. For IgA nephropathy it is synpharyngitic, and PSGN has a smoky or cola colored urine, and RBC cast present for this R for rapid progressive glomerulonephritis. And NPGN it has a mixed picture. So mixed means it should have both hemat and proteinuria. And lupus, like hemat is always present, proteinuria may or may not be present. Coming to the complements, this IgA nephropathy has a normal picture. The others like PSGN, it has a low, complements go down. Lupus nephritis also complements go down. MPGN, this persistent low C3 is present. Whereas coming to the RPGN, it's a variable picture. Coming to the antibodies, PSGN like post-streptococcal, you can remember anti-streptolysin. Yeah, ASO is like easily remembered for this PSGN. Other thing is anti-DNase B antibody. For lupus is a manifestation of SLE. So anti-nuclear antibody ANA, anti-dsDNA antibodies are positive. For RPGN, you have to remember the glomerular basement membrane. So anti-GBM antibodies, positivity, ANCA associated vasculitis, because it has like history of systemic vasculitis. You can also remember the ANCA. And coming to the course, PS unit is self-limiting. It resolves by itself in 6 to 8 weeks. For the others, SLE, if it is left untreated, it will be progressive. The MPGN or the RPGN, they have severe, it has a progressive and severe kind of illnesses. IgA nephropathy, it is intermediate. If it is left like recurrent hematuria, if it's recurring, then it may progress to CKD, chronic kidney disease. So this is all about the different lesions causing this syndrome. So if you like this video, please like, share and subscribe. Thank you.